Hello and welcome everybody to the fourth webinar in our conversation series that we here at AAHD are holding with the partnership of the All of Us Research Program. Today's conversation is going to be around long COVID, the disability that it can cause, and the All of Us Research Program and how they work together. We do have CART services and ASL going at this time. We'll be running through the entire presentation. The presentation will also be recorded, and you will receive that recording in a few days after we finish up the webinar. I have an esteemed panel with me today of activists and researchers and long COVID patients and medical professionals. So I don't want to waste any time, and I'm going to nod over to my our moderator for the event, who is Ezra Spear. Ezra is based in Oakland, California. He's a researcher and a patient, and he is a person who lives with long COVID. He has created his own long COVID studies database. He's a member of the Patient-Led Research Collective and Long COVID Moonshot. And outside of all of his long COVID advocacy, he's an independent operations and tech consultant who helps organizations thrive through difficult periods of growth. So he's a man of many hats, and I'm going to send it over to him to get us started.
Thanks so much, Devin, for the introduction and for putting this all together. As you said, my name is Ezra, and I'm really excited to be moderating today's session with our great panel. I also wanted to say, just for folks who may not be able to see the video, I'm a white man in my mid-30s, brown hair, blue eyes. Rather than belabor the point, I'm going to go ahead and hand it off to our first panelist today. We're going to have a few folks be giving short presentations about long COVID, what it is. We're going to be talking about research considerations, talking about the patient experience. But first, I'm really excited to introduce our first panelist, Dr. Monica Verduzco Gutierrez. Dr. Verduzco Gutierrez is an accomplished academic physiatrist and professor and distinguished chair of the Department of Rehabilitation Medicine at the Long School of Medicine at the University of Texas Health Science Center at San Antonio. She is also the medical director of critical illness recovery and neurorehabilitation at Warm Springs Rehabilitation Hospitals in San Antonio and chief of the physical medicine and rehabilitation service line at the University Health Hospital System. Her area of clinical expertise is the care of patients with traumatic brain injury, stroke rehabilitation, interventional spasticity management, and long COVID. So Dr. Verduzco Gutierrez, go ahead and take it away.
Thank you so much for having me here today. Just again, I'm Monica Verduzco Gutierrez. Describing myself, I'm a Latina woman, and I have brown hair, brown eyes. I, again, along with being a physician who cares for patients with long COVID, I also have lived experience with long COVID myself. And so kind of the question that I'm going to get to and talk about today to open things up with this very esteemed panel is to talk about infections, post-viral conditions, and then what that means for COVID and for the long COVID community. So I really want to, say this is something that's very important, and I want to help the audience understand the connections between these things. And so first to say, long COVID got a lot is, something, of course, that's very important, but this was not the first post-viral infection-associated chronic diseases. This has been something that has been ongoing for some time. So what is a post-viral condition, or what is also considered an infection-associated chronic condition? So really, we are learning about what the pathophysiologic mechanisms are for these. But this is when something that's developed after having a prior infectious disease. So it doesn't always have to be a virus. Sometimes it may be from a bacteria or any other type of infections. And so I will tell you, in the past, they've not put a lot of money or research into some of these topics. But some of the most common post-viral conditions, or ones that we've seen for a while, an example would be ME/CFS, or myalgic encephalomyelitis, which is, also sometimes known as a chronic fatigue syndrome. Also, post-treatment Lyme disease is another infectious associated chronic illness. Now we know that multiple sclerosis is very much impacts people who've had Epstein-Barr virus. So it is also considered an infection-associated chronic illness. POTS, or dysautonomia, that often happens after an infection. And there's sometimes some neurologic conditions that people also don't think that happen after infections, along the way of POTS, but also before we'd seen patients who had Guillain-Barré. And so that's where, nerves are impacted by the immune system. And usually that happens sometimes after a vaccine, but other times after having an infection, a GI infection with Campylobacter. The other one that is maybe common, or not, it is actually not so common, but it's something that I had seen in my clinic before, was post-polio. And so we knew that poliomyelitis in a small percentage of people may have caused considerable disability as far as, the impact on motor neurons and causing a lot of weakness. And then some patients who had had polio actually decades later developed post-polio syndrome, which is, again, there's considerable weakness that can happen after this and impact on the neurologic system. So a lot of times people, when they have these illnesses, they will have impairments that cause disabilities in their life. So these post-viral conditions are going to have an impact on persons with disabilities, someone who may already have. We've seen some people in the ME community who have gotten COVID and then have had an exacerbation of their symptoms. We know that we have someone who has post-polio and already has kind of a weakened respiratory system. We are concerned for things that if they get infections again, they may have poor outcomes because of their decreased respiratory function. This is also something that in patients even who have spinal cord injuries, we were concerned if they had quadriplegia, that they wouldn't be able, that they could have more impacts of the SARS-CoV-2 virus, which is the virus that causes COVID-19. All right, so COVID-19, I think everyone has heard about COVID-19, the infection that causes COVID-19 disease. And as you know, there is a spectrum of presentations when patients have COVID. Some patients have asymptomatic COVID, mild, moderate, with a pneumonia. Some have severe, where they're in the hospital. And definitely we saw that at the beginning of the pandemic in 2020, where patients had a lot of sickness, a lot of hospitalizations, deaths, unfortunately. And I will tell you, from a physician perspective, what I expected mostly to see was patients who are hospitalized, who were going to, have critical illness impacts that we had seen in other patients who had had critical illness from other causes before, and know that patients would just be generally deconditioned, and of course also have cognitive changes and mental health issues, as someone who which can occur after having a stay in the intensive care unit for so long. But I think something that really was surprising to clinicians and healthcare workforce was the number of patients who had impacts from COVID who were never hospitalized. And that's something that we started to see, patients who were asymptomatic, who had very minor infections, who then go on to develop what we're going to be calling long COVID today. And so we are now seeing, there's different definitions, World Health Organization, CDC. When I think about long COVID, this is when someone either has an exacerbation of a current condition, develops a new condition or symptoms, or has ongoing symptoms from their infection. And they can, they can get ME/CFS, they can get POTS, they can get dysautonomia. There is also 200 symptoms that patients may have, or over 200 symptoms. And this has been described very well in the literature, including our own panelists here who have been authors of this work. And so really, I always say, if I've seen one patient with long COVID, I've seen one patient with long COVID, because they all can have different presentations. And so there's definitely, again, we're learning more about the pathophysiology, meaning what's happening when someone has COVID, and then in some people now develop long COVID. And so, and it can really happen to anyone, and that's something that everyone should know. And so when you look at household pulse survey data, so this is something that they started taking and asking people when they're doing the household pulse survey. This is from the census about long COVID, and the current numbers show that the percentage of US adults who have ever experienced long COVID is 17.6%. So that's quite significant when you think about the number of people that are in the United States. And so in some of these people, it can be quite debilitating. It can impact their life. It can cause new disabilities, or, further impair the disabilities that they had before. And so that's what makes it so significant. And definitely, I think it's been, as I said before, these kind of chronic infection-associated chronic conditions have been under-resourced, under-researched, and definitely we have to put more attention to it. And so as far as long-term effects of COVID-19 and long COVID and similarities to others, I think that we still have more to see and learn going forward. Definitely we know that patients are impacted in so many different ways. Some of my thoughts are what's going to happen decades down the road. Like we sometimes see later, certain viruses may impact and increase risk of cancers, like hepatitis C virus, like Epstein-Barr virus, like human papillomavirus. So, what are we going to do? Many people, especially there's also a risk when you get in multiple infections.
Just going to jump in. We seem to be having some issues with Dr. Verduzco Gutierrez's video, so we'll wait to see if she emerges back.
Sorry.
Hey, are you back? I
I'm
think you
back. Somehow I
cut
got
out a little bit.
cut out. I know. It's like,
Yeah.
whoa, what happened? Okay, was that my sign to take me away? Okay.
No, nothing like that. But
Okay.
we lost you when you were talking about other viruses that have these long-term sequelae like HPV and EBV and so
Right.
forth.
So, right. And these sequelae are, having risk of getting cancers down the road. So there's still more to see what's going to happen with SARS-CoV-2. I hate to be the bearer of the bad news, but, we're going to have to see what happens to the population and if it's going to become even more disabling than it already is. Last concern that I'm going to bring up is that what happens with people with disability. And one data point from the household pulse survey is it shows the risk of, or the percentage of persons who live with disability who've ever had long COVID. And that percentage is 28.4% of persons with disability have ever experienced long COVID. So again, it's something that it already can impact more persons who have disability. I think my take-home message is going to be, we need advocacy, we need research. Thank you for being here today to listen to this. That's the first step in advocacy. Advocacy is keeping yourself educated, keeping on and pressing our representatives in Congress and continuing to press on the NIH or even outside funders. We need to be, really broad about who is going to be supporting our community going forward. And of course, also educating healthcare workers so that they understand the impacts of long COVID on the disability community and making sure they know how to address these issues. Thanks.
Amazing. Thanks so much for that overview. And, I think as a member of the long COVID patient community, I really just appreciate the work that you've done to highlight the importance of this issue and to make it one of your, professional focuses. It really, the work that you're doing in your work really makes a big impact on us. So thanks so much for sharing all that and for being here.
Oh, you're welcome.
Yeah. All right, our next panelist is Claudia Sherman. Claudia Sherman is a creative director, a long COVID patient, and a founding member of the grassroots advocacy group Long COVID Moonshot. Formed in October 2023, the group has brought a fresh energy to long COVID advocacy, successfully advancing the conversation around the need for long COVID research funding by combining patient experiences with research perspectives. Claudia Sherman lives in the California desert. And I will be handing it off to you.
Hi, everybody. Thanks so much for having me. I'm here today to kind of go over my experience as a long COVID patient and then talk a little bit about the need for advocacy about, around this type of research. For the visually impaired, I am a white woman with shoulder length blonde hair and green eyes wearing a tan colored shirt. I do live in the desert south of Joshua Tree National Park. I live on the border of an unincorporated community and tribal land. So we are already in a difficult position for healthcare, even when it's, something people are more used to seeing something like a snake bite than something like long COVID out here. I had my first infection in 2021. And while I recovered from the initial infection, I had a series of health conditions start to crop up over the next 8 or so months that gradually took away my ability to work. I went to see a doctor. I got some basic blood work done. And when all my blood work came back with flying colors, the doctor very forcefully insisted that this was all in my mind. It's because I wanted to be sick. I've convinced myself that I'm sick, and I just needed to go home and change my own mind, basically. This was really difficult and demoralizing. This kept me from getting further care for about 6 months. At this time, I was put into the Medi-Cal system, which is California's low-income healthcare program, because I had basically lost all of my income due to my inability to work. I went to a second doctor who thankfully believed some of what was happening to me because her son was having some of the same experiences. He had previously been a marathon runner and was now unable to leave the couch. So I was able to go and get some testing done. And then it was my introduction to what I think of now as Alphabet City, because I started to learn about all of these different conditions that other people have had for so long that can crop up from a viral infection: POTS, MCAS, PEM. I have dysautonomia now. Through inductive backwards reasoning, we've learned that pretty much my grandfather's line in the family all have Ehlers-Danlos, and it has all started to flare up with everyone getting COVID infections. Of course, we didn't have the technology back then. We just knew that grandpa had scoliosis, but that's something that can occur in the Ehlers-Danlos hypermobile systems. So it's been really hard to realize all of these things have been going on for so long outside of the mainstream public view, and that we didn't have this knowledge going into, the public didn't have this knowledge going into the crisis. After the second round of research referrals, I got tested. I had EKGs, EEGs, I had a PET, I had 5 MRIs, I had a Holter exam. And I'm able to pass all of these tests. And that's another thing that's very common to long COVID patients. Like, the technology just doesn't quite exist yet to catch some of the biomarkers that we probably are presenting with. So then I entered my online era of going to Reddit, going to Twitter, starting to follow some of the amazing researchers that I'm so honored to be in the room with, and starting to put this information together in a really backwards fashion, that I might have gene differences that led to me developing some of these conditions or made me more susceptible to them, that things like the MTHFR gene that looks really rude when you write it out is really relevant to my life now. And thankfully, I've regained enough cognitive function to be able to understand and digest and put some of this information together. But I realize that that is such a privilege, even for the average working American, not to mention after getting brain fog. So I think it's really important that we all come together, share our experiences, find these commonalities, study things together, find what's similar, find what's different. And I was so excited to learn about the All of Us program because here is, you see people all the time say, why isn't anybody putting all of our information together and finding what is common between us? And people are doing that. We just need to get the information out that the program is here. It doesn't cost anything. You can get genetic testing, and for those of us who are very low income now and who don't have access to some of the out-of-pocket options that others might have that are not in our situation, especially to have an option that allows you to participate without a huge out-of-pocket cost is just incredible. So, yeah, this was just a really exciting opportunity for me. As Ezra and Devin both said, I went on to become a founding member of Long COVID Moonshot, which is an advocacy group of patients who are kind of in my lane. We're informed about research, informed about civics, kind of sharing that information between ourselves, and then trying to find programs that will benefit long COVID patients and bring them to the forefront, particularly trying to find that legislation that will promote research funding for long COVID. We need to get ahead of this thing really early. I'm someone who lost loved ones to the original AIDS crisis, and I see that happening. We're in our 5th year of this, and I want us to not wait that long. So thanks so much for inviting me. I look forward to any questions about the long COVID patient experience, because lived experience is really my bailiwick here, and hand it back over to Ezra. Thank you so much.
Thanks so much, Claudia. That was fantastic, and so many parts of your story really resonate with my own experience as well. Would love to introduce our next panelist, Lisa McCorkle. Lisa McCorkle is a person living with long COVID and the co-founder of the Patient-Led Research Collaborative, a group of long COVID patients conducting research on long COVID and advocating for better policies for disabled people. She is the co-author of several prominent long COVID research studies, including a review in Nature Reviews Microbiology. She's coordinated a patient-led biomedical research fund of $5 million towards long COVID and associated conditions, and has co-created scorecards that evaluate meaningful patient engagement in research. She has a master's in public policy from University of California, Berkeley, and a background in social safety net policy and labor and employment issues. Lisa, take it away.
Thank you, Ezra. Hi, everyone. Thank you for having me. I'm going to share some slides as I talk. So maybe can someone confirm you can see those?
They look great.
Awesome. Thank you. So as Ezra mentioned, my name is Lisa McCorkle. I am a white woman with brown hair. I'm wearing a reddish pink top with white flowers. And as you said, I have had mild long COVID since March of 2020, and am one of the co-founders of the Patient-Led Research Collaborative, or PLRC. So today in my portion, I'll be covering just who PLRC is. I'll discuss the disproportionate impacts of long COVID, the importance of participating in research for long COVID, and then some best practices for research into long COVID. So to start off, Patient-Led Research Collaborative is a group of people with long COVID and associated conditions, which we've heard a little bit more about these already. So that's things like ME/CFS or POTS. We formed in April of 2020 after the co-founders were not recovering after a mild case of COVID-19. And at that time, in spring of 2020, there was really little discussion about this possibility of having long-term symptoms after a COVID infection. So we conducted the first research on long COVID as a response to this. And now we are over 50 patient researchers and advocates across 10 countries. We are majority women and majority identify as disabled. And we have published about 21, I think it's over that actually now, over the papers over the last 4 years, including 6 that were our own patient-led research. And then we regularly work with external teams on their long COVID research projects. We've authored 2 of the most cited long COVID research papers, including one that was the first to document the 200 symptoms of long COVID, and one that was a review of long COVID research. And then we've also contributed through our research and through our lived experience to policy documents and public health guidelines. And I think our work really demonstrates the importance of patient-led and patient-centered research, and how centering the patient experience can really lead to better research overall. So we'll get into the demographics of long COVID. Dr. Verduzco Gutierrez mentioned a little bit about this. This is from the CDC Household Pulse Survey data, and looks at who is currently experiencing long COVID as a percentage of all adults in the United States. So this survey only looked at adults, but we know that long COVID also impacts millions of children. There's unfortunately just not as much research on that available. So I'll focus on what it looks like among adults. So the highest prevalence age range in adults seems to be in the 30 to 60-year-old range. The Hispanic and Latino population is most impacted, followed by multiracial individuals. Transgender people are disproportionately impacted, with 12.5% of American adults experiencing long COVID who are transgender. And this really demonstrates the importance of long COVID care, like clinical care, also being gender competent care. And then we also see that long COVID is also more prevalent in cisgender females. There's also a higher prevalence of long COVID in people who had a pre-existing disability. Additional risk factors include lower income and the inability to rest in the first 2 weeks of having COVID. So that can also translate to generally people who have lower income, people who have to work and don't have access to paid sick leave. As of January 2022, which is over 2 years ago, it was estimated that there were up to 4 million people out of work in the US. So likely that number is higher now. But this isn't even the full picture of the impact of long COVID on people's lives. 1 in 4 people with long COVID limit their activities outside of work in order to continue working. So they don't do as many chores, they can't help with childcare. We know from our lived experience and through research that people with long COVID experience a decreased quality of life. There's a high economic impact, as well as it already impacting people who are already experiencing material hardship. So 42% of people with long COVID report food insecurity, and people with long COVID are twice as likely to experience housing insecurity. There's significant medical costs associated with having long COVID. There's an estimated average of $8,700 per year. And we have a lack of clinical care, of adequate clinical care, with only 7% of providers being very confident diagnosing long COVID and only 4% very confident treating it. This is largely due to a historical neglect of infection-associated chronic conditions like ME/CFS and POTS, some of the common diagnoses that people with long COVID are receiving. And I will say a note that, while we do not have an FDA-approved treatment for long COVID, having access to quality care is still really important, particularly for accessing disability benefits, for accessing SNAP or food stamps, and accessing work accommodations, some for symptom management, largely where we find any relief, even minuscule for symptom management. It's learning from conditions like ME/CFS, which about half of people with long COVID have, or dysautonomia, which about 2/3 of people with long COVID have, or just through the patient community and what other patients are trying. So particularly with a disease like long COVID that we still need a lot of research on, it is so important to participate in studies as patients. Recruitment can be one of the most time-intensive aspects of a research study. So patients being eager to participate and signing up can really speed up the research quite a bit. Being part of research can also help you as a patient learn more about your own illness, particularly when, like in the All of Us research program, you get your results back to you. You help the community at large. You get all of us to answers faster by participating in research. And then also, if you're able to partner on research studies, your hypotheses and your input on study design can really make research more effective and efficient, being representative of the patient experience. But I do want to note that there are risks and downsides to participating in research that have to be weighed. So this includes whether participation could trigger post-exertional malaise or a crash. If you're in a clinical trial, you may have side effects if you receive the treatment, or if you get the placebo, you may not have the opportunity to try the treatment. The research could require a lot of time or travel. Hopefully that would be reimbursed, but that should all be weighed in your decision-making process. And then if you have to go into a clinic, there's also the risk of COVID reinfection. But on the research side of things, hopefully we can, researchers would require masks, high quality masks, and really reduce that risk as much as possible. Now I want to highlight on the research side of things some key points to consider if people are interested in doing research on long COVID. So without the patient perspective, if patients aren't meaningfully engaged, we often find that researchers fail to build off of existing research into infection-associated chronic conditions, largely because of what I mentioned before, the historical neglect. They're not aware of it. Many of these conditions were not taught in medical schools. But patients often are aware of these conditions and the research available because we're learning from people with ME/CFS. We're invested in this because it is very much part of our lives. So an important part of studying long COVID is building off of the existing research, but also another way to do that and ensure that is engaging patients. And I'll explain on the next few slides a little bit more on how best to do that. Another important aspect of conducting long COVID research is doing cross-illness research. So this is including cohorts of people with ME/CFS, POTS, and other common diagnoses after long COVID into research with long COVID, and then also measuring who in your long COVID cohorts have these conditions. An important aspect that I already mentioned is creating a safe environment, as safe as possible. So masking, doing virtual when possible, having rooms available for people to rest when they arrive to clinic, and then after any testing before they have to travel home. We also need to ensure of a comprehensive selection of patients. So there's a lot of misconceptions around who has long COVID, and that results often in not the right selection of patients. So things to keep in mind is that most long COVID patients were not hospitalized in their acute infection. Many actually had mild acute cases. Many didn't experience respiratory symptoms at the beginning, although some did. But a lot of that early research on long COVID only focused on hospitalized patients, on people who had respiratory symptoms, and who had more severe cases. So we want to make sure that there's a more comprehensive selection. Many people with long COVID were not PCR positive or antibody positive. So it's important to include a clinical diagnosis subset of people with long COVID. And then really ensure that the cohort is reflective of populations most impacted. So consider gender, sex, race, socioeconomic status, age, all of the things I covered earlier. And then in study design, it's really important to account for the nature of the illness when designing studies. And again, patient engagement can really help ensure of this. But a really key aspect of long COVID, a symptom that most people with long COVID experience, is post-exertional malaise. And this can be triggered by the research itself. A lot of tests that people do as part of their research, or even the travel to a research site, can trigger post-exertional malaise. So considering that when you're taking samples and understanding that that could impact your research results. Also consider exacerbation around the menstrual cycle and hormonal impact. We do see differences in this, so track where people are in their menstrual cycle. Many people who menstruate experience this exacerbation at certain parts of their menstrual cycle. So really understanding that and incorporating that into your research. Be careful with questionnaires. What we see a lot is anxiety and depression questionnaires not requiring a mood component and just being diagnosed based off of symptoms like fatigue. And we really do need to see that mood component in order to adequately diagnose anxiety and depression. Illness duration is really important. So we do see in ME/CFS and some other conditions that, depending on how long you've been sick, your presentation of your condition can look different, and actually some of your tests come back different. So conducting analysis by how long you've been sick can be important. Understanding that there are many phenotypes potentially of long COVID, or at least several. There's still ongoing research on this, but at least separating out by diagnoses like ME/CFS, POTS, symptom clusters to start as a sensitivity analysis. And then also considering what treatments patients are already on and whether that's impacting results. So an example of this is if you are doing a tilt table test, but your patient is on beta blockers, that is going to impact the results of the tilt table test. So it seems pretty intuitive, but often this is something that is missed in long COVID research. And then these are the scorecards that we developed in partnership with the Council of Medical Specialty Societies. I'll put a link in the chat in a bit. The point of these scorecards were to establish a new baseline of what's considered meaningful engagement of patients, and are really to be used by both patients and traditional researchers alike. I'll focus on two specific scorecards. The first is patient burden, which evaluates whether the engagement is accessible, if practices are trauma-informed, if the research organization is responsive to patients, and if there is compensation. And then the second is integration into research process. So we really want patients to be embedded throughout the research process, from hypothesis generation to study design, analysis, publication, and attribution. So really all throughout the research process. So if you as a researcher are engaging patients, or you're a patient wanting to be involved in research, we really recommend using these as tools to ensure that patients aren't being tokenized in this process and are really meaningfully engaged, because that's what's going to get us to better outcomes for patients. And that is all I have. So thank you so much. And I have my contact info on the screen.
Amazing. Thanks so much, Lisa, for taking us through all of that. Really amazing things for researchers to keep in mind. And to me, those household pulse survey numbers are pretty intense to see, and it just demonstrates how big of a problem long COVID is. I just wanted to say a quick reminder to everybody watching that we will have a Q&A once our panelists are done with their presentations. So definitely fill up that Q&A section in the Zoom, and we'll get to those questions in just a few minutes. I'd like to now introduce our next panelist, Jacqueline Luciano. Jacqueline E. Luciano is a first-generation Filipino-American wife and mother of two. She's also a former Illinois Department of Public Health surveillance nurse and was working as a regulatory consultant until she became disabled by long COVID and associated diseases in January 2022. Jackie has experienced firsthand the challenges of navigating a complex healthcare system while battling long COVID and myalgic encephalomyelitis, ME, both of which lack FDA-approved treatments. Her current projects are in collaboration with Long COVID Justice and ME Action, and she's a narrative architect for Listening for the Long Haul, a living history of long COVID. Jackie holds a Bachelor of Science in Nursing from Loyola University, Chicago. Jackie, please go ahead.
Thank you, Ezra. Thank you so much. And thank you to everyone here and for the amazing presenters before me. I am Jackie Luciano, and my pronouns are she, her. I am a middle-aged Filipino-American woman with shoulder-length wavy brown hair. I have brown eyes, and I have black headphones on, a black shirt filled with lint, and there's a beige wall and pillow behind me. And now I'm going to share my screen for my presentation. Hey, can you see the slides?
We can.
Okay, will this be, okay, is this okay? Or do you see do you see the full screen, or do I have to lower the Zoom?
It looks good. We see the whole slide.
Okay, great, wonderful, thank you. I am very honored and privileged to be here to present my experience with long COVID, associated diseases, and invisible disabilities. Please note, this is not intended to be dismissive of any visible disabilities, as that also poses its own challenges and hardships. I'm simply sharing my own experience, spreading awareness. I'm not giving any medical advice, and this is for educational purposes only. And yes, a copy of all my slides will be made available. Do you recall where you were and what you were doing when the world shut down in March 2020? It was a time of chaos. People didn't know what to believe and what was going on. Many were dying and falling ill to a virus that was spreading like wildfire. People were scrambling, emptying store shelves, which led to a shortage of items such as toilet paper. Our nation also had a shortage of personal protective equipment, such as masks, gloves, gowns, and eye protection, all failing to properly protect healthcare workers, first-line responders, and essential workers. At that time, I was working as a regulatory nurse consultant for long-term care facilities. The realization hit me hard. This is why I became a nurse. As much as I wanted to be home with my family and children, I couldn't. I felt a strong calling to be out there on the front lines, helping those in need. I adjusted my corporate role to meet the urgent demands of the lockdown, offering support and assistance to frontline staff and residents at a nursing home, while simultaneously trying to understand the confusing messages and guidelines disseminated by public health organizations. Let's not forget, they refused to acknowledge for several months that SARS-CoV-2, the virus responsible for causing COVID-19, is airborne. Scientists were ignored, and we were receiving conflicting information from the very institutions that are meant to protect and safeguard our public health. On April 2020, I had direct exposure to SARS-CoV-2. There was limited testing at the time, so I don't know if I had it, but I needed to isolate for 2 weeks because I had COVID-like symptoms. I returned to work despite lasting fatigue. We had several infection control surveys by public health inspectors, and during weekly public health webinars, there was not ever a mention of long COVID or that pandemics are mass disabling events. We lacked this message on the front lines. Then, by December 2020, the COVID vaccines received emergency use authorization and mandates began in 2021. I was hesitant to get the vaccines because I was in remission of my then misdiagnosed chronic conditions, but decided to get vaccinated because I was told they were safe, effective, and helped prevent transmission. I received a total of 3 doses and had worsening migraines, nerve issues, and pain, A month after my booster in December 2021, I was shocked to learn I was positive for COVID. How could this be? More symptoms continue to develop and persist for days, weeks, months, and years, such as disabling fatigue, breathlessness, unrefreshing sleep, pain, palpitations, blurred vision, rapid heart rate when changing positions, inability to be upright, and dizziness when sitting, standing, or walking. I lost my sense of taste and smell. I have stomach pains, hair loss, weight gain, brain damage, tremors, and post-exertional symptom exacerbation, also known as post-exertional malaise, or a crash that lasts weeks at a time. My case is classified as mild because I didn't require hospitalization and didn't die. At least I thought I didn't. I still grieve and miss my former self, and my life hasn't been the same since 2021. Shown here is a tricolor ribbon developed by long haulers. The gray color represents loss and grief, teal, hope, and support, and the color black, loneliness and isolation. Please note that the patient coined term and hashtag long COVID was developed in May 2020, way before vaccines were administered. Since my SARS-CoV-2 infection, I've lost my ability to consistently care for myself and my children. I lost my job. I lost our family's health insurance plan. I peed on myself twice in public, and I fell earlier this year when trying to get out of bed. I've been absent as a wife, absent as a mom, absent as a daughter, a sister, a friend, an aunt, and godmother. There are many, many hours and days I spend time being horizontal, lying down, keeping stimulation and activities to a minimum because gravity and physical or cognitive exertion worsens my symptoms. Long COVID reactivated dormant viruses in my body and triggered conditions such as POTS, myalgic encephalomyelitis, also known as chronic fatigue syndrome, MECFS, and hypermobility, Ehlers-Danlos, and mast cell activation syndrome. I spent thousands of dollars trying to find knowledgeable specialists, medications, supplements, and answers, and there hasn't been any significant improvements where I can at least brush my teeth and take a shower every day without causing a relapse. One of the most painful questions I've been asked is from my own 2 children. What happened to you, Mom? I often receive questions and comments such as, "Are you better yet? But you look fine." Doctors say, "Sorry, we don't have any medications to help. There's not enough research." And even by fellow nurses, "Keep trying harder, push through." And this is one of the worst advice I received. When I kept pushing and working in January 22, I had a fever for 8 weeks and I was refused to be seen by infectious disease when my primary doctor ordered a referral. I had worsening migraines and blurred vision. I was so weak and concerned that I was having a stroke. During another appointment, a cardiologist said to me, "Oh, I had that fatigue too, and it went away. Take a Tylenol before your stress test for your fever, and you'll be fine." Another doctor ordered to go outside for a walk for 30 minutes, despite explaining how short of breath and fast my heart rate was beating when standing up. Long COVID clinics are still prescribing graduated exercise therapy, even when patients present with post-exertional symptom exacerbation. What happened to do no harm? This is like telling a patient who has broken legs to go run and ride a bike. Exercise is harmful as a first line of treatment for patients that exhibit this very physiological dysfunction, and it's not based on one's effort preference. I cannot thank ME Action and Long COVID Justice allies who shared their wisdom and knowledge to stop, rest, and pace. During one ER visit, when I had an exacerbation of my POTS, I was accused of faking my invisible symptoms by paramedics and fellow nurses and was threatened to be sent to the psych unit. Because I'm knowledgeable of my conditions and the staff treating me were not, I was told I was just having anxiety. I was so livid, but then I realized I'm being treated this way because the designs of our healthcare system are failing disabled patients with chronic, complex health illnesses. I thought that by becoming a nurse, I would learn what happened to my mom when she became disabled in the 1990s. But I didn't learn the truth until I developed long COVID and learned from others about MECFS. According to Dysautonomia International, The quality of life for POTS is comparable to patients on dialysis for kidney failure, and the functional impairment is similar to one with congestive heart failure. Patients are not faking invisible symptoms. $3.7 trillion is the estimated economic impact that long COVID has on the US economy. The disability rate is at an all-time high at 34 million. Over 4 million are absent from the labor force. The barriers to long COVID care and support are insurmountable. It took 2 years to see a POTS specialist. There are so many of us without disability support and are facing stigma, racism, homelessness, and financial hardship. 6 million children in the US have long COVID. We also need more pediatric research, and thank you to long COVID families for all that you do. It's evident long COVID is a public health crisis, also acknowledged by Long COVID Moonshot, COVID-19 Long Hauler Advocacy Project, and Long COVID Action Project, and more. When will there be an Operation Warp Speed to define, detect, prevent, and treat long COVID? Long COVID Justice and allies are calling for research justice, community accountable data, and truly equitable policy. We need to break down the systems based on inequality, ableism, and that put profit over people. This slide asks for a call to action. We can begin by accelerating inclusive research that's adequately funded and significantly more than $1 billion annually. We need a healthcare paradigm shift. Our bodily systems are interconnected, and the root causes to our symptoms should be identified. The current medical questionnaires and assessments are very limiting and useless, and we are often not believed because test results come back supposedly normal. Clinical guidelines and treatments needed to be updated well over 4 years ago. Medical professionals and healthcare centers need the education and support to help manage long COVID and complex chronic health conditions. I'm so grateful for my rheumatologist, holistic providers, and close friends who think outside the box to help me. And there needs to be an integration of complementary modalities to not only address SARS-CoV-2 persistence and immune dysfunction, but also the damage it has done in our bodies that need repair and healing, especially on a cellular level. Medical records need to include the patient perspective because they lack accurate representation and documentation, confirmed by my own regulatory background. Disabled and chronically ill people require support and accessibility, which includes clean air, testing, and masking. Many participants are excluded due to this lack of safety. An investigation is also needed to analyze why and how many long haulers are being denied disability benefits. I call for transparent public awareness and honest public health messaging. Help us destigmatize and depoliticize long COVID. Center and include individuals with lived experience as we have sustainable solutions. You don't want to wait until this happens to you because long COVID can happen to anyone, anywhere. Lastly, there must be global collaboration to expedite this warp speed as millions are suffering around the world and lack access to care. Support us to continue to build our international long COVID toolkit to help one another. Knowledge is power. Here are links and books I'd like to share, such as Long COVID Survival Guide, Disability Visibility, and Let This Radicalize You. Sharing my medical experience and being vulnerable before you goes against my training as a nurse and my upbringing by Filipino immigrant parents. But I've had enough with staying silent and by following the systems that are actively erasing and excluding us and denying one's individual truth. It's time for a revolution. I am here because the best resources and experts are within the patient and caregiver community, and I thank them for helping save my life. I miss being able to give direct patient care, so with my limited energy, I hope to help save lives this way and pass the love and kindness forward. In solidarity, thank you for listening, and I do believe that together we will make a difference.
Thank you so much for sharing your story so vulnerably and powerfully, Jackie. I hope I'm speaking for everybody when I thank you for spending your precious energy sharing this with us today.
Yeah.
Now my turn to tell you a little bit about my experience. So let me get my slides up. I'm going to assume you can see my slides and go ahead and get started. The slides are mostly so I don't forget because my memory isn't as good as it used to be, but I developed long COVID after an infection in September 2022. I had done what I thought was what I was told to do. I got vaccinated, I got boosted twice, and my infection happened just about a week and a half after my second booster at the time when I had been told I would be at the peak of my immunity to COVID. I had no idea I was high risk. I actually still don't know whether I was high risk for long COVID, but both of my siblings have also since developed long COVID symptoms. And so, I went into getting sick with the idea that I would probably be fine, but I knew that there was a risk. And unfortunately, I'm one of the unlucky, 10 to 20% of folks that had long-term consequences. My primary symptoms have remained pretty stable in the 18 months I've been ill. I have post-exertional malaise or post-exertional symptom exacerbation. And for me, it's primarily triggered by cognitive and social exertion. This is similar to symptoms of ME/CFS, myalgic encephalomyelitis. And I'll be honest with you, after this webinar, I'm going to feel pretty awful for the rest of the day because this kind of work has a direct impact on how I feel physiologically. I also have POTS, so when I stand up, my heart rate goes haywire, and I have numbness in my extremities. My toes go numb all the time. I don't know why. There's no doctor has ever been able to tell me much about it. Unfortunately, the cognitive dysfunction that I experienced, especially early on, and the consequences of using my cognition have forced me to mostly stop working. And even though it's been about 18 months, I've remained very, very ill. During this time, I've spent a lot of my energy that I do have trying to dive deep into the long COVID research and literature. My coping strategy is to learn as much as I can, and that's what I've been doing. And I had a visit to the ER last year where the ER doctor looked me straight in the eyes and said, "I believe that you have more knowledge about your illness than anybody else in this entire hospital building." And while I really appreciated that doctor for being humble and, you know, communicating with me as somebody who is deeply invested in my own health, to me, that was an incredible indictment of the medical system and the research system to know that as a patient, I'm the expert. To this day, I have not found a care team that is knowledgeable about long COVID or able to help me manage my symptoms. The only things that have helped me are things I've found on my own, largely by learning from the long COVID and other chronic illness communities, doing my own research and bringing it in. Since I've joined advocacy groups like Long COVID Moonshot and research groups like Patient-Led Research Collaborative, and I've participated in several research studies in one clinical trial, soon to be another. And I'm also a participant in the All of Us research program. So I'm going to talk a little bit about my experiences with research. I've learned a lot about biomedical research since I got sick. This isn't something I had a pre-existing knowledge base in. And I want to talk about some of the specific barriers to research participation that people with long COVID face, and some of the accommodations that researchers can make to sort of mitigate some of those challenges. And some of these are things that Lisa and others already touched on. The first is energy limitations. So many people with long COVID have a very limited amount of energy. So a normal clinical trial that might require 5, 10 different site visits is going to be really, really difficult And, you've heard about PIM. It may cause, days or even weeks of recovery times for people just to participate. So I strongly recommend that researchers break up visits, allow people to take rests, allow for remote participation. There are some really great teams out of Yale, out of the University of Alabama, just to mention two, out of Scripps, to mention one more, that are doing large-scale distributed trials that don't require any in-person visits. Focus time on important tests because it's really critical to prioritize that resource of time. Second, many people with long COVID have significant cognitive dysfunction, memory issues. So I strongly recommend that researchers simplify their instructions, limit surveys and questionnaires to those that are really necessary. Let people take breaks during them. Have flexibility on the timelines that they can be submitted on, and provide materials in multiple formats. For example, some people with long COVID really can't handle in person. Some prefer in person. Some can't handle video chat. Some prefer it. Some can't do any of those and require communications to happen through text, through email. So if there's a way that you can allow for all of those sorts of participation, you'll be able to capture a much greater, much wider variety of people with long COVID. Consider mobility limitations. Many people with long COVID have difficulty or challenges with mobility. So ensure that clinic visits and tests are accessible to those at all levels of mobility and severity. Know that many of us with long COVID have experienced medical gaslighting, and so may enter into a clinic or medical environment with a lot of resistance and a lot of frustration. So it's really important to ensure that your research team, your clinical research coordinators particularly, are well versed in what is long COVID, what are the things to expect from the participants in research studies that you'll communicate with. Ensure that the process is imbued with compassion, and be prepared for the fact that some participants may have some surprising reactions. We're coming from a place of trauma here. It's not unrealistic for that to happen. And so preparing your team to ensure that those can turn into positive interactions is really, really important. It's a way that you can actually contribute to the healing of individual people, even in a research context. Consider that many of us with long COVID are very concerned about the risk of reinfection, not just of COVID, but of anything else. And especially as we see news about potential new pathogens, coming into our communities, at minimum, researchers focusing on vulnerable communities should mask by default, wearing an N95 or higher quality respirator. Many people with long COVID were never diagnosed with acute COVID. Sometimes that's because it was early in the pandemic and tests were simply not available, or potentially now we're largely told not to bother with testing anymore. And so research and care should not be limited to those with a positive test. Now, it's fine to group people with a certain test with people who have a clinical diagnosis. That's totally fine, but it is very, very important to include as many people as possible in research. We've seen today that in the industry, it's called social determinants of health, but many people who are already marginalized by society because of identity, because of occupation, because of socioeconomic status, because of disability, are more affected by long COVID. And so it is so important that our research studies include a population that is representative of those groups. And recruiting from those groups may be difficult. And so it is important for researchers to spend time and money conducting outreach to those communities, like via this AAHD webinar, to ensure that our communities are fully represented. And finally, I spoke about my own experience having to stop working, but many of us with long COVID have had to end work and are struggling financially. And so it is really appropriate to compensate patients, whether that's for participation, transportation, and other things. I want to talk briefly about my experience with All of Us research program. I actually know somebody in the long COVID community who is a researcher who is involved with All of Us, and I actually learned about it because some folks in a non-long COVID related community were participating. And I was like, oh, this seems cool. Sort of like one of the largest research studies of all time. But when I read about it, I thought, wow, it is so important for me, somebody who is experiencing a serious health issue, to be included in this cohort. Because if I don't take the step to do that, then we may not be represented in the research results. The other things that I really appreciated about it is that there is some potential personal benefit you can get if you choose. By submitting your genetic samples to the program, you get the results of some genetic tests. Now, those don't necessarily have direct clinical applications, but as someone who has always been a little bit unsure about sharing my genetic information with some of those private testing companies, I thought this would be a really great way to learn a little bit more about myself, my family history. And the other thing that I really appreciated about All of Us is there is the opportunity to participate remotely. So the surveys can be filled out on your phone or on your computer, and you can submit samples via the mail. So you don't have to go to a clinic, though I did. I found the surveys to be, there's a lot of surveys, but I did find it helpful to be able to take breaks and break them up over several days. I actually did go in person to UC San Francisco to give my specimens, and the staff there was really nice. They made it very easy. It was a short visit, and I got my genetic testing results pretty quickly. So if that's something that you're interested in, I would highly recommend participating. Now, finally, I want to wrap up with some research opportunities because I know and I hope we have some researchers in the All of Us program here on the call today. I think that there's some, with a cohort the size of All of Us, I think this is a great opportunity to look at some long COVID cohort. So first of all, how do you identify us? Identifying people with long COVID is a challenging problem in the world of long COVID research. So here are 3 ways that you could do it. And if you would like assistance, digging into this more deeply, feel free to reach out to me or PLRC, because I'm sure we'd be able to help provide some guidance. But the first is, many folks who do get clinical diagnoses of long COVID, there is an ICD-10 code. And as All of Us has access to some EHR data, you should be able to sort on that code. Also, there are ways to diagnose COVID. You could use EHR data to diagnose long COVID or to identify potential long COVID by looking at an acute COVID diagnosis and then looking at common sequelae. I've posted in here, there are papers that talk about ways to do this. I think it is still early and we do not have a strong consensus about the most appropriate ways of doing this, but there are smart people thinking about it, and I encourage you to dive into the literature there. And then I would encourage folks to look at the All of Us survey questions for folks that have listed long COVID as a condition that they have. Some research questions that I'm curious about that I would love somebody much smarter than me to take a look at is, what family health histories are typical of people with long COVID? As I mentioned, I have siblings with long COVID. And so is that common or is that an outlier? What kind of genetic susceptibility may there be to long COVID? Is it possible for us to warn people that they may be at higher risk? That would be highly useful information. And with a cohort the size of All of Us, we may even be able to get some of those answers. And then I think, again, with the cohort being as it is, I'd love to know what correlations are seen between the social determinants of health that are captured and a long COVID diagnosis. It is so important, as Lisa discussed, to collaborate with groups like Patient-Led Research Collaborative and PCORI. Include patient reps in your studies, not just as tokens, but as folks who are deeply invested. In fact, more invested in many cases than researchers in the outcomes of research, to build hypotheses, to identify areas where things can be streamlined, to ensure that outcome measures and that the framing matches with the patient experience. ensure that your studies are recruiting from diverse groups. I actually am so concerned about this that I built my own website, longcovidstudies.net, that simplifies the listings on clinicaltrials.gov to make it easier for people with long COVID to find studies to participate in. And collaborate. One of the great things we've seen in the long COVID research world is just how many collaborations, both within and between institutions. These collaborations have been incredible. And I just put a link in here that the NIH Recover program, though, though being a bit controversial in the long COVID patient community, has captured a lot of data, and that data is now being made available to researchers. So what could you do by combining Recover and all of us data? Probably something pretty cool. So that's where I'm going to wrap up today. I really appreciate everybody for jumping in, and we are going to move to the Q&A section.
Yes, we are. First of all, I would be remiss if I did not extend my unending gratitude and compassion for this community. This is such an important conversation. The Q&A has been going off constantly. It's been great to see. A lot of them have been answered already in the chat, but one of the biggest questions one of the first ones that really struck me was, how do we disabled people participate in research for long COVID or any health condition if we cannot safely participate? That is too many, so many, in parentheses, healthcare workers will not take COVID precautions. We are stuck then risking catching it again if we try to participate in research. So how can folks participate and get past that? And I will leave that to whichever one of you wants to take that answer.
I can start. I think that, I mentioned a couple strategies in the talk that I gave. We really need researchers to implement strategies that de-risk our participation. This needs to be a collaboration here between patients and researchers kind of need to meet us where we are. And so I would encourage potential participants to be really clear with researchers about what you are able to do and what you are not. So for example, a clinical trial that I participated in last year, the study center where my visits were being held changed its masking policy in the middle of the study. And a lot of the participants in that study pushed back and said, this isn't going to work for us. And a new location was found. There is a lot that researchers can do. And sometimes, while I wish that they would kind of do all these things for us without us having to ask, I have found that sometimes there's really positive responses when we ask. So again, I don't think it should be our responsibility at all, but I would encourage folks, especially if you are participating, to keep those boundaries. And remember, as a study participant, you always have the right to leave the study. In your consent documents, there will be a person to contact if you want to withdraw. And that is one of the most powerful ways that you have to make sure that your voice is heard. Lisa, maybe did you have anything you want to add about inclusive research or kind of de-risking the research process?
I think the answer you gave was great. I mean, one of the barriers that we're coming across in terms of, requiring masking is that researchers themselves can require masks for themselves and for their patients, but may not have control over other patients that are within the healthcare facility or other researchers there. So, or, practitioners there. So there potentially could be a risk at all times. I mean, whenever I go into a healthcare facility, I'm wearing a high quality N95 and recommend doing so. But in terms of, if you're the study that you're participating in, or even at your healthcare provider, if they're not already requiring that of study participants and their own study personnel. Organizing and trying to get them to is, I guess, the best way to do it. Unfortunately, that's just where we're at in terms of, you know, the society we're living in now, as we do have to push for those rights and those protections.
Great. Yes. Thank you both for those thoughtful responses. I think that a lot of it does have to unfortunately fall on the clients, and it ought not, to your point. So another question is, my physician was unaware of and then minimized the validity of the research for the new monoclonal antibody for persons who are immunocompromised once I made him aware. You guys are all vocal advocates. So what do you suggest to advocate or find a physician or provider within a network who does informed care and will kind of give them the answers? And Monica, I see your hand up, so go on ahead.
Yeah, sorry. Now I'm at the airport, so hopefully you can still hear me.
You're good.
All right. What I would say is, yeah, reach out to practices who maybe take care of persons who have autoimmune disease. Maybe reach out to cancer centers. They would have, access to monoclonal antibodies. And the other thing you can do is reach out to the companies that make the medications, because they're going to know which providers, which companies, which, institutions have the medications, and it's their job to get those monoclonal antibodies into patients. So you can also use that as a resource for yourself.
I'd also add that one of the best tools I found as a patient in terms of getting care, even though I still don't have the care I would like, has been the chronic illness community. And I know that like some of the resources that Jackie shared includes organizations that have Facebook groups, Discord chat groups, and other resources where patients do maintain lists sometimes, or local folks might be able to provide feedback about whether a particular practitioner is amenable or compassionate or not. Sometimes not can be just as useful information as is. And so I would encourage folks to use those networks. Unfortunately, there isn't like a central place you can go. There's no like Rate My Professor or ZocDoc for this. But I think the community is very welcoming.
Oh yes, Rate My Professor. That takes me back a bit. So an anonymous attendee would like to know, with the slides I believe that Lisa shared, she said, I see all the high numbers on the percentage of those dealing with long COVID, but I don't seem to see those reflected in the people that I know. Is it that mild to severe are combined in one number? Their symptoms are fairly severe, mostly on the couch, can't work, can't sit up for too long, and they are not currently aware of anyone else they know being that disabled by long COVID. So in the research, are those numbers being combined, or is there a breakdown somewhere that maybe not be seen in the communities?
Sure. So within the household pulse survey data, it combines, it's anyone who's experiencing long COVID, so regardless of severity. There is a section of the analysis where they look at who experiences any activity limitations due to long COVID and then significant activity limitations due to long COVID. So that may be more reflective of what you're considering. I can look up just right now. So for example, people who experience significant activity limitations from long COVID as a percentage of adults who currently have long COVID is about 23.8%. So about a quarter of people with long COVID experience these significant activity limitations. But I'd also say, generally, as a society, we don't often talk about our illnesses to people around us. And And so there's probably people in your life that you aren't aware of that are experiencing long COVID, even maybe more significant long COVID, or more severe long COVID. And it's just a nature of the illness that people kind of disappear from society as a result. So you don't necessarily know that people are experiencing this. But also we just generally don't talk about it as much, or people don't know that they have long COVID. They just know that they've, never recovered fully after their COVID infection. So I think it's something that we really need to talk about more, but still to this day, not everyone knows about long COVID, and people can't prescribe it necessarily to themselves. They aren't being diagnosed, don't have healthcare access. So I think what we're seeing in our communities is much lower than probably the prevalence that actually exists, just due to kind of how we talk about these invisible illnesses. Does anyone have anything else to add on top of that?
I guess I'll just say that I've had multiple conversations with friends who say, I don't have long COVID, but, and then go on to describe a health issue that, based on my knowledge as a non-physician, would probably meet the criteria for a long COVID diagnosis if a full workup was done. And so I think there's just a lack of knowledge about what long COVID really is and what it encompasses in the community as a whole, maybe to capture some of those more mild cases especially.
And there are even physicians and clinicians living with long COVID who are either not knowledgeable enough to know what that is, or they don't want to be stigmatized, because unfortunately there's a lot of stigma. We haven't talked about that, but I know that's something that impacts the disability community in general. So
yeah, and hearing Jackie's story, coming from the perspective of a previous clinician, my experience going to doctor's appointments is it is not uncommon for the medical assistants and folks I interact with when I tell them I have long COVID to nod and say, oh yeah, me too. It's really, I think it's much more common among that group, especially because there's just been so much more exposure to COVID in the clinical setting.
Yeah, thank you for sharing that. Actually, when I wasn't recovering from my acute COVID in 2022, I started asking a lot of my colleagues, hey, how are you doing since your COVID infection? And I would get feedback like, I can't work out anymore. I can't go outside for a walk, or my sleep has been impaired. So I don't think people were also, like you said, that they weren't putting together. And thank you, Dr. Gutierrez, for mentioning the stigma, because especially as healthcare workers, sorry, but we have to hide how we feel sometimes. Thank you.
No, I definitely agree, and thank you for sharing. We'll have time for one more question, and I think this is really geared. I think this is something that Claudia might be able to answer too. Somebody asked, how do you tell the difference between cognitive decline due to long COVID in your experiences versus maybe just normal cognitive decline due to aging or anything along those lines, or is it hard to do because they are the same? How do you make that delineation?
Right. It is pretty difficult right now. What we're seeing in people is there's accelerated cognitive decline, and it really depends on your age cohort. So my mother also has some long COVID symptoms, and I know she experiences brain fog, but research is showing that she's gaining about 7 years of chronological age onto her cognition. When I'm at my worst, I'm gaining like 30 years onto my cognition. So I'm approaching, I'm like, oh, mom, I'm thinking like you. And it's kind of a joke in our family because my mother has a tendency to assume that everybody's having the same experience she's having. And I have to keep going like, no, I shouldn't be forgetting groceries at the store. I can't just chalk that up to like, oh, we're all getting old, aren't we? Because I'm only 45 years old. Like, I still have to work. I have a lot of things to do. And I think, in general, people have a bias towards the status quo. People are inclined to not want to take in new information. They want to believe whatever they already know and have the world be the same predictable, wonderful, safe place. So that is a really hard part with sharing your story, is that people will want to write it off to almost anything else. And so you do have to just get really loud about holding your boundaries, you know, acknowledging what you know is right. I've had really increased anxiety as a result of my long COVID, not only situational life anxiety that's rational for anyone experiencing a new illness to have, but I know that it's different from the anxiety that I've had in the past because I've already had it. So when people say like, oh, you were already anxious when you were younger, isn't that just the same anxiety? I can go, no, because I was already anxious, I know that this is different. Because I've experienced, you know, normal clinical depression when I was younger, I know that what's happening in my brain now is really different. So it does come down to really holding the line. Any kind of testing you can access, of course, is really valuable. Any kind of, I use a lot of brain training to kind of try to track myself. So even something like, how fast can you complete the New York Times mini crossword? And the mini is like only 5 or 6 answers and they're really short. In the beginning of my journey, it would take me 3 minutes to do it. And now I get it between 30 seconds and a minute every day. And so, you know, having little, it's really funny, but little stuff like that, or understanding what kind of cognitive stress bothers you, because I can do my design job all day long, but doing any type of math work or doing any type of frustrating work, if I'm emotionally frustrated, if I'm activated while I'm trying to think, I lose it. I'm like a toddler. I will tantrum out, you know, and so that kind of noticing those patterns in yourself, you know, but definitely a lot of it is just being really clear to people that this type of decline doesn't happen in a month or 2 months. This is, you know, we expect that as we get to slide into our golden years, we're allowed to loosen our grip a little bit, but this doesn't happen to people that are 25 in only 3 months. This is something that's happening in our brain. So thank you so much for the question. And I know it's really hard. You just have to have that in yourself, that you know what's happening to you.
I'll also toss onto there that I did find one drug that helped with some of my cognitive symptoms and also coincidentally helped with some of my mood symptoms. And so when you take an intervention that changes your ability to think, it sort of, to me, again, as a patient, not a doctor, not giving medical advice, it tells me that that wasn't like permanent aging, you know, cellular, whatever. It's actually an active disease process that, if treated appropriately, could maybe even be completely resolved. And so I think that, unfortunately, you know, even the off-label treatment that I've been able to access is not something that many folks are able to. And so it's difficult to tease these things out. It's another example of where better medical education and more research into these things would allow us to have better information.
Great. Yeah. And that's why, you know, this all ties back to, you know, the need for more medical research and the need for more people to do stuff like joining the All of Us research program. And there's more information about that in the chat as well. So thank you again for all of your time and all of your expertise and all of your energy. I know these can be longer moments for you, so I appreciate it. And to the audience, we had such amazing questions. I've been furiously keeping them so we can hopefully work on some answers to come out with some of the outreach. You will receive the recording and all of the slides that have been shared today if you registered. So whatever email address you gave, it'll be sent there. We have a survey in the chat as well. So please tell us about your experience with this webinar, and look for one to come in June that is covering mental health and the need for more community outreach in that field. Thank you again so much for your time, and you can feel free to leave.